So that's why we have a bit smaller pixel pitch and large number of pixels on the large detector, and also 16-bit depth. It is important for the 3D image quality. All right. So just think combination of tube and detector. So small detector use a small field of view. So that's why possible to use narrow target angle tube. All right. On the other hand, so large detector use large field of view. So we need more target angle to get wide exposed area by it. All right. So this is the 3D image sample between 14-bit and 16-bit imaging. The image signal was improved by high dynamic range reconstruction. So low contrast resolution improved, as you see. So we can see the suppressed white enhanced signal around the bony structures. All right. So next, I want to touch X-ray mode. So the doctor use X-ray during procedures. They are roughly fluoro mode and acquisition mode. All right. In the fluoro mode, sorry, back to here. All right. In the fluoro mode, two types there. So one is subtracted fluoro called like load map. The other is normal fluoro. It is used for the every procedures. So in the acquisition mode, there are three modes like a DSA, DR, and cardiac, 3D acquisition. Okay, it is necessary to consider how to use them properly. So regarding clinical situations, right? So from dose setting perspective, the fluoro mode use nanogray per pulse. On the other hand, acquisition mode is used microgray per flame. All right, the amount is more than provides better image quality, so means better signal noise ratio and contrast than fluoro. So if you want to reduce radiation dose as well, so please consider trend in each procedures. All right, so this is a trend of exposed type between diagnostic case and treatment case. So in the diagnostic case, the rate of fluoro is around 50 to 60%. The procedure time also shorter than treatment case. On the other hand, so the rate of fluoro in the treatment case is around 70 to 80%. So if you faced on the radiation dose issue, so we should think about the trend of your procedures and think about which is effect to reduce dose. All right. So actually, so Japanese customer use low dose fluoro mode for treatment case, low dose acquisition mode for diagnostic case. All right. So they think about the weight for the fluoro for each treatment case. So, but if we use too much low dose setting, the image quality also getting worse. So we have to look for acceptable lower dose setting by collaboration with application specialists in the vendor. All right. the dose and image quality is quite relevant subject in the clinical case. All right. So basically, radiation dose should be lower as well as possible, but need to care image quality. All right. So I want to introduce care and clear technology in this session. Okay, so this is our solution to keep image quality with low dose setting. All right. The established theory for general X-ray is high dose provides high image quality. So it is exactly, but as I mentioned, the radiation dose should be reduced as well as possible and keep image quality. Okay, how can we control this point? Okay, and care plus clear technology come through our needs. So care is contributed to reduce X-ray exposure by reduced radiation dose, monitoring, and reporting. So clear is image quality, even at the low dose. So we think both combination and make better image quality with low dose setting. Right? So care is short name of combined applications to reduce exposure. So there are several applications. So I introduce a few applications today. All right. So care position. So it is useful for patient positioning without fluoroscopy while moving C-arm or table. The operator finds white graphic on the live monitor during system movement, right? So this center cross marker is displayed as image center position for next exposure. All right, so it provides radiation-free patient positioning. All right, so next one is care profile. It is available on last image hold screen. So last image hold means the last frame shown on live monitor when stopped and exposed. All right. So it is available for collimation and filter setting. So collimation is important to reduce dose area product. So it is linked to patient dose directly, and the scatter radiation amount also reduced. So therefore, image quality also improved. Right? So filtering is to suppress the halation, useful for the lung field, and so on. So care profile provides a radiation-free collimation and filtering. All right. So next is clear. This technology provides better image quality even with low dose. So in terms of image acquisition and image processing. All right, so I introduced two of them. The first one is clear control. Okay, so it is worked for optimizing image contrast and brightness by unique histogram analysis. The bright area, so like a lung field, make a halation. So I mean white out impression due to difference of the patient sickness. Okay, so clear control defined this point and adjust contrast Okay, so you can see the difference on the right side image. So white signal was suppressed, so device signal become more black. So as I said, in care profile explanation, so filtering also important to avoid halation. So, but we can also use clear control together, so it make better image quality. Okay, so this is available for all 2D imaging. So I mean, so fluoroscopy and acquisition mode. All right, so next is clear view. So it is enhanced overall image quality when using low dose setting, right? When we use low dose setting, a lot of noise signal there. Okay, so displayed image also become noisy and blurred, and clear view is kind multi-frequency filtering. The system detect noise signal and device signal individually and apply smoothing filter to the noise signal, apply boosting filter to the device signal. Okay, so multi-frequency filtering is mainly used for all angio system, so all vendor product, so in the current situation. Okay, so clear view is available for 2D imaging. So we can use this for low dose setting to maintain image quality as well as possible. So it is important to understand system characteristics and also system application like care and clear on our product. So this knowledge makes safety a procedure and will be your basis. All right. So next topic is what is required of a radiographer at Cathlab. Okay, so a bit into detailed jobs. So firstly, I touch in neuro examination. All right. So doctor is main operator, should focus catheterization and system movement. Okay. So radiographer support doctor as a clinical supporter or sub-operator. Okay. Sometimes, so radiographer control the system movement and so on. Okay. In the neuro examination, so some image processing are required, like a DSA post-processing and 3D acquisition support and so on. Also radiation dose controlling. So radiographer make procedure smooth and safety. All right. So in terms of the patient monitoring, so nurse in charge, so confirm blood pressure, ECG signal, and medication support, and so on. All right. But during the procedure, so all staff work as a team. Okay, this is quite important. All right. How about cardiac examination? So the main structure is the same with neuro. So doctor are in charge CM and table movement and catheter control. Nurse also do the patient monitoring and doctor support. So in terms of radiographer, so image processing like difference image creation, filtration and correlation. So, and quantification tool is important. So the doctor requests to calculate stenosis rate by quant applications. Okay, so dose controlling is also important for cardiac case. So heart is moving, so that's why high frame rate used for cardiac case. All right. and CM angulation becomes steep degree. So that's why the total dose increase faster in the cardiac case. Okay. And patient monitoring is also important for the radiographer in the cardiac case. So sometimes complication happens suddenly. Okay. So that's why to make good relationship with team and monitoring patient vital during procedure. Okay. In addition, so multimodality evaluation is trend in the cardiac region. For example, use coronary CT and coronary MRI image for the decision of strategy, or use another modality image as a treatment support tool, right? So I will explain this point later. All right, so in the abdominal procedure, so mainly use fluoroscopy and DS acquisition. All right, so image processing are required, like a reference image creation, filtration, and DSA post-processing. So it's a bit close to the neuro examination. And image supporting is quite important for abdominal region. So the patient, so like a dynamic CT, dynamic liver MRI, and so on. So these information are required when depicting feeding artery and thromboid cell. All right. In addition, cone beam CT on the angio system is required. So in similar case, it has high resolution than CT, so it is useful for confirming small vessel. So I also show clinical images on session 2 today. All right, so this is a summary. So as I mentioned, some specific requirements for each procedure. So if you want to contribute in Cathlab, so below 3 points are important. Okay, so first one is understanding procedure workflows. So this is most important thing. Anticipate next step and prepare for it. All right. So for example, so this is common neuroaneurysm coiling workflows. So it is structured several steps: pre-procedure, control acquisition, pre-3D, and so on. So if you know these workflows, so we can expect the next step and prepare for next requirement. All right. So now I pick up pre-3D acquisition. So we have a several step for smooth workflows. So 3D imaging is quite important in the neuro region. So it is used to decide treatment strategy and confirm important vessel and so on. And then, so injector setting is one of important topic for 3D imaging. So correct value is necessary for better image quality. All right. And 3D mode selection. So we have a similar 3D protocols for each purpose, like high contrast imaging and low contrast imaging, high resolution mode. So anytime, so doctor requests better image quality for 3D, so we need to advise to them which protocol is best solution, right? After 3D, so make working angle. It is correct view for target region. So we can make it by 3D image, right? And so similar useful application on the system. So 3D automap is one of them to the system. And the system can be reached same angle with 3D image. All right. So if we know over all workflows and the requirement for these steps, so possible to respond these steps quickly and smoothly. Okay, it is quite important requirement for the radiographer in the Cathlab. All right. So second one is understanding support application. So it is necessary in the current situation. For example, coronary stent enhanced application. So due to this device development, so coronary device are getting thin, small, and unvisualized in the fluoroscopy. Therefore, for safety treatment, so cardiac applications are mandatory, so especially in the complex case. All right. So on your left, so cardiac application sample there. So doctor find the stenosis rate from quant application. Okay. So stent enhanced image taken by specialized protocol. So better to know each application if you have on your hospital. And don't be shy to suggest like this useful application to the doctors. All right. Suggestion from radiographer is quite important for Cathlab. All right. And CT or MRI image can be used on angio applications. Okay. So CT image useful to confirm the calcification in the coronary tree. So this is the sample of the Cto Guidance application. So we can find calcification information on the image. And left ventricle 3D volume data is used for the ablation case. So arrhythmia, so like atrial fibrillation. So it is, so this image so will be installed on the mapping system as a cathedral navigation. Okay. So useful application software is developing steeply. So that's why, so get better understanding, so each characteristics and use it during the procedures. Okay. So these guide, so your procedure effectively and safety. All right. And third one is multimodality approach. So for example, coronary CT and MRI is used for a lot of diagnostic cases. So we can use it during intervention case as we see on the previous slide. Yeah, so these images are helpful to decide treatment strategy. Okay. And also confirm anatomy information, vessel tree and soft tissue and so on. So before procedure, so we need to confirm diagnostic case images if patient has it. All right. So I show the clinical case of the neurothermal procedure. The patient have an MRI image with contrast medium before angio examination. So on the angio image, we couldn't see soft tissue information like a tumor shape and around the structure, but angio image provides high resolution vessel information like on your left here. Okay, we can find a fine vessel on the angio image. On the other hand, so MRI image has enough soft tissue information like on your right image, So we can see trauma figure clearly with brown color. Okay. Then we use a 3D fusion technique. So it is used to volume data set, and this application require landmark, which is a same structure like a bone. Okay. So in this case, angio volume data and MRI volume data are fused by bony structure. So this technique enhance both characteristics as fused image. So in terms of the high resolution imaging and soft tissue imaging, right? So after fused images, so we can see the detail of relevant vessel and the hemorrhage point. Okay, like this here, like this. So to get better understanding for both image characteristics, so angio system has a high resolution image for the vessel, and MRI image also has a good at the low contrast imaging. Okay, so it is quite important support to decide treatment strategy with more and more information. Okay. So angio volume data, so reconstructed from angio 3D imaging. So thin slice data around 1 millimeter to 2 millimeter is required from another modalities. Okay, so if you want to make like this image, so image data preparation is required. All right. Sorry. And one more technique is 2D, 3D fusion. Right? So this uses fluoroscopy from two directions for fusion step instead of 3D volume image. Especially for the aorta procedures like a stent graft and the dissection and so on. So these are requirement huge field of view and a lot of contrast medium for 3D imaging. So in general, so it evaluated by CT. So we can use the CT volume data for 2D, 3D fusion. So the fused image can be used for the 3D roadmap image. Okay. The work steps are on your right. So two direction fluoroscopy and adjust CT position on X, Y, and Z axis and each rotation. So in this case, also we use a spine and the pelvis as a landmark. So as you see, this fusion technique with another modality is quite helpful for current trend in the clinical field. All right. So the doctor can see the vessel figure all the time. So it make contrast medium amount reduced. So that's why please have a wide perspective, not only angio system itself, but also another modality images. All right. So this is required for the radiographer. All right. So we will go to the basic information Cathlab. So some preparation are needed before patient enters the Cathlab. So we make a patient transfer position like on your here, like light picture. So patient easy to access to the table. So due to offset position between table and the arm. Okay. And to avoid accident, so movement block is mandatory. So sometimes patient touch table controller as a grip to access the table. Okay, then So patient position should be fixed to avoid fall from table. All right. Of the risk in the Cathlab. So patient preparation is quite important to avoid unexpected accident. All right. So these are sample image of the accessories. So head holder and the cushion set used for the neuro examination, handrail and body support used for the abdominal case. If dyno CT, so cone beam CT on the angio system required in the abdominal case, so the arm occur the strict artifact and the raising arm make better image quality. Okay, and arm holder used for the brachial and radial access, especially in the cardiac cases. All right. So in terms of the image quality, if patient move during DSA acquisition, so motion artifact will be occurred. Okay, we can see it as a white signal on the DSA image. These artifacts can be fixed by pixel shift function in the post-processing, but for smooth workloads, so we should fix the patient and avoid artifact itself. And if the patient use local anesthesia, so please communicate to the patient before DSA. So inform like, don't move please for a few seconds. So this communication also avoid motion artifact. All right. The examination is performing under clear environment. So therefore, peripheral equipment should be covered with straight covers. It also prevents blood and contrast medium from entering the system. All right, then we into radiation dose information. So we have a 3 definitions about dose value. So first one is system dose. It is measured directly on the input value of the detectors. Okay, the system changes this value against the zoom format size for keeping signal noise ratio constantly in every zoom format. All right. So the next is skin dose. It is measured 30 centimeter in front of detectors. So skin dose limitation for fluoroscopy is defined in each country. All right. So 10 Röntgen per minute. So it means 88 milligray per minute. So it is used as a normal regulation in Indonesia. All right. So this regulation means that X-ray more than this limitation. So X-ray generator control exposed value in real time. Okay. As you can see, high contrast mode, okay, with 20 Röntgen per minute for fluoroscopy mode. So it is useful for the maxed out situation. So when patient size is quite big or using steep angulation, we faced on the maxed out situation. Okay, then the image quality getting worse, but X-ray amount achieve skin dose limitation. So the system cannot supply more power in this situation. So therefore, one solution is switch to the high contrast mode. The system supply more power due to increase the limitation value. All right. So while using the high contrast mode, the system will sound an audible alarm. All right. So the last one is the patient entrance reference point. called PERP. So this point set on the 15 centimeter below isocenter. Okay. So this value is defined by IEC regulations. So this point is common. Apply or angio system, even vendor changed. All right. The system measuring radiation dose by dosimeter in real time. So those value on dosimeter use this point to calculate the dose value. All right. As I said, so dosimeter put on the angio system. So it is used for the monitoring radiation dose in real time. Okay. On our system, so it is combined as care watch. So it is displayed dose area product called DAP, air karma rate, or accumulate air karma value at the patient entrance reference point. So on live monitor in the examination room, so in the control room, we can find these value at the real time. Okay. So after close the patient, so radiation report will be created automatically. So care report include the detail, those information in the case. So we can find actual exposed X-ray value for each acquisition and total value. So radiation dose from every examination. So it used for the patient aftercare, right? So this report stored as a DICOM format. The customer send it to the PACS system or any dose analyzer system. Okay. All right. So this figure is air karma intensity in 0 degree and 19 degree. So in 0 degree, so X-ray expose posterior side to the anterior side direction against the patient. So air karma intensity is evenly distributed. All right, you can see the evenly distributed here. On the other hand, in 90 degree, air karma intensity is changed. All right. So X the distal side, this is the tube side. So tube side intensity is increased. All right. So it is important knowledge for dose reduction for the staff. Okay. For example, so nurse want to approach to the patient. In this case, they should avoid to stand on the tube side. Okay. So nurse have to approach from the detector side. Okay. So due to of air karma intensity. All right. So this knowledge sharing is quite important to sync room environment. So staff stand position and also operator stand position and so on. So that's why, so please keep in mind this intensity trend. So tube side is a bit higher than detector side. So it is quite important thing in the Cathlab. All right. So in the last topic, I want to show real Cathlab picture and look for room environment. So this is general cardiac lab, so biplane angio system with small detector there and large display here. So this is examination room monitor. So doctor confirm live signal, reference image, and a lot of alternate signal like ECG, blood pressure, PACS image, and so on. And the system controller, and also power injector, and pumping. So syringe pumping for medication set on the table side, and hemodynamic system connection here, and the catheter box in the corner of the room. And radiation dose shield here, and we can find also surgical light also replaced from the ceiling. All right, from another view, so we can see the nurse PC here with radiation shield. So catheter cart here, medication cart here, and oxygen system here from the wall, right? And the big lead glass window set as between control room and examination room, and the system cabinet set in the wall. All right. One more another angle. So we found the iBus system. So emergency preparation like a PCPS and IABP here. And similar garbage can there. It is classified for the bio-contaminated and the normal one here. Okay. And accessory box is here. Sterile cover and something inside. So like this. So we found a lot of equipment in the cardiac room. So we must think room environment in terms of the patient load and the staff load. So with no collision and safety usage. All right. So, and I want to introduce hybrid OR system. So what is hybrid OR? So it is different from general Cathlab. So hybrid OR is angio system in the operating room. So in hybrid OR system, so procedure type also different. So combine the open surgeon and interventional procedures. For example, so new aneurysm clipping. So after and during open surgeon, so doctor confirm vessel information with angio. Okay, so it is quite helpful to check the surgeon progression and the effect. All right, so this is a hybrid OR environment. So it is totally different from general Cathlab. So almost all procedure under free anesthesia. Okay, and the patient use a surgical table. So patient position change in each procedures. So a lot of surgical light and monitor on ceiling. So a more busy environment than general Cathlab. All right. Set around the table. So patient image is displayed on the big wall monitor. So in the hybrid room, a lot of tube connect to the patient. So we have to take care tube tension and collision and getting cold when we move the angio system or table. Okay. And the table layout also change regarding patient position. So prone positioning used for the spine procedure, head open surgeon. So supine positioning used for the stent graft case and the structural heart disease. And sometimes side lateral position used for the thorax procedures. All right. In the hybrid system, so we take several times procedure simulation for safety use and smooth workflows. All right. So thank you for paying attention. So that's all from session 1. So I will confirm the chat box. Oh, a lot of chat here.
Hi.
All
Hello,
right.
Hajime-san. Good morning.
Good morning.
Iwan speaking. How are you, Hajime?
Yeah, I'm good. Thank you
Yeah.
for paying attention. Yeah.
Nice to meet you, even though in the online session. Yeah, Hajime, I will help you, Hajime. Actually, from the participant or student, our college, we already has around 5 the question. The question number 1 is coming from Bu Devi, and I believe that Bu Devi quite familiar with Artist G system. She has been working for decades in the Cardiac Center Hospital in Jakarta. The first question is, where we can find the clear view in the Siemens Artist Z system, since we are facing a lot of requests from the cardiologists in applied.
You mean the specialized protocol for the stent visualization?
Yes, correct. I mean that the question where we can find the clear view in the Siemens system, Artist Z system.
Okay. So Artist G system, we can find a clear view application, but it is internally setting. So that's why we cannot see the clear view itself on the system. So clear view is used, eye noise reduction in the organ program editor. We have a similar type of the filter, the strength of the smooth filtering and so on. So if you find eye noise text on the organ program editor, so it is just same as a clear view.
Okay. Yeah, because maybe as you know that after stent implant, maybe the doctor will be request for the high resolution image, and sometimes they think this is possible to do the same technique with the Artist Z system, Hajime-san.
Yeah.
Okay, thank you, Hajime. And the second is question coming from Mr. Slamet Budi Kurniawan. The question is, you said that in the case to provide a better image for the cardiac examination, we should increasing the frame rate. The question is, there are any correlation with the increasing frame rate with dose itself? Thank you, Hajime.
Yes, but in cardiac case, so we have to think about a maxed out situation. So as we see, so I will share my screen again. All right, so we have a skin dose limitation here. So this is defined in each countries. So if we increase the flame rate and the dose, so both value, so the maxed out situation come faster and faster. So that's why image quality getting worse. Okay.
Yeah.
So we have to think about reduce the flame rate. Instead of that, so we increase the dose value as well. So we have to think about the combination that if you want to use the high dose value, so high dose value supply high image clarity. So it is totally exactly. But we have to think about the maxed out situation and also patient dose. So that's why combination is quite important. High dose value setting with low flame rate, or high frame rate and middle or low dose setting value. So, but it is up to the doctor's thinking and the doctor's perspective. So these image impression acceptable or not. So that's why we have to make good relationship between the customer and the application specialist, and we look for the certain acceptable value as well.
Yeah, okay. So it's mean that 10 Röntgen per minute or 20 Röntgen per minute depend on the country regulation, yeah, Azime.
Yeah. So, but this value is used in the Indonesia system or Indonesia system.
In the most of the Asia country system. Okay.
Yeah.
I think that the next question is related with your slide, Mr. Hazime. The question same. How does both of DAP, dose area product, and air karma measure by system?
Yeah. Thank you for a nice question. So we have a dosimeter on the tube side. So radiation dose calculated the DAP, so dose area product and accumulated air karma. So we use this point, okay? So patient entrance reference point. So this is set as from 15 centimeter below from the ISO center. So this is the definition in the IEC regulations. Okay, so that's why system calculate the value which displayed on the dosimeter. So all the time we calculate this point. So it just only see the distance from source to this point.
Yeah, and then the next question is, there are maximum acceptable dose regulation for one-time catheterization procedure, Hazime-san?
Yeah, actually, so 2 glade is one of the timing to think the patient care. To Röntgen, 2 glade.
2 grade.
So 2 glade is one of the trigger. So if the more than 2 glade, so we have some risk of the skin. So that's why 2 glade is first trigger for each procedures.
Oh, okay. 2 gray, yeah, 2 gray, yeah. Okay.
2 glade, so 2000 milliglade,
Okay, Hazime. We have the next question from Mr. Angri Ihsan. The question is, good morning, Mr. Hazime. Can I ask you question? Care and the clear technology is integrated for Siemens system tool or for other system also?
So the care and clear is our not option. So our artist Z and artist product. So all the time, so care and clear is installed already. Not option.
Okay, so it's mean that the integrated, yeah, not option for artist Z system. I think that the question is also mentioned they are available for other system. It's mean that if the system is not Siemens system, but the user will be installed clear and care technology, it is possible.
Sorry. It is impossible. So care and clear only work on our system. So each vendor has like this technology, how to reduce the radiation dose and maintain the image quality. So something like Clarity IQ in the Philips system. So maybe the old vendor has a very close technique in each angio system, I think. Yeah. Okay. But care and clear is also work on our system, on our product.
Okay. So it means that the care and clear is human unique application software, yeah, integrated with the system, but impossible to install with the other system. But we believe that the other system maybe also have the same program, how to reduce the dose and how to increase the image quality, correct?
Exactly.
Yeah. I think we have the lot of question from Bu Devi. Yeah, Bu Devi also asking the question: can the artist G system have multimodality approach with the other?
Yes, possible on the artist G system. So, but please confirm, do you have X workplace? Or sometimes, so these, I introduced a lot of application like this one. So this is work on our X workplace, not on the artist Z system itself. I mean, so 3D workstation is required. So that's why if you have the 3D workstation for called X workplace, and please confirm the option and so on. Maybe all the artists Z lineup work as well, like this.
Okay, Mr. Hazime, thank you for your explanation. Baik, rekan-rekan, jika ada yang ingin bertanya kepada Mr. Hazime, silakan bisa ditanyakan secara langsung, atau kalau mau ditanyakan juga boleh lewat kolom chatting, nanti saya bantu sampaikan. Silakan, jika ada yang ingin bertanya langsung pada Mr. Hazime, kami persilakan.
Izin bertanya, Mas Iwan.
Ya, Mas Ari, please, Mas Ari, silakan.
Okay. Halo, Mr. Hazime Osato.
Hello.
Okay, my name is Ari, and I am one of the students in the Health Polytechnic Jakarta, and I also work in the National Cardiovascular Center Harapan Kita Jakarta. And it's rainy day in Jakarta recently, so apologize if there is some noise in the background. Yeah. The first is you said that you used to be a radiographer and work in the hospital recently before join with the Siemens, yeah, right? I want to hear your opinion about is it necessary to academy to open a new class or a new major to study interventional angiography, yeah, for radiographer, or is enough if we put it in global curriculum as a small subject to study in the academy? Yeah. So I want to hear about education in Japan about the interventional angiography or radiography. Is it to be a new major or to be a general study in educational radiography in Japan? And the second question is, I want to hear your explanation also about is it possible if the hospital running a angiographic examination with a radiographer inside? Because for some examinations such as electrophysiology study or EP study, the doctor usually said that they don't need radiographer to join with them during study.
Yeah.
So what's your opinion according to your slide, yeah, about the job description of the radiographer in the Cathlab? Yeah. And this situation is also happen in Japan or not? Yeah. Okay, thank you. I think that's enough for me. Thank you, Mr. Sato.
Yeah. So thank you for good question. So the answer for first question, so it means the radiographer education in Japan. So basically, so on-job training is main training purpose. So I mean, so elder radiographer train the younger and the newcomer. So sometimes we use basic clinical topics, presentation, and also attend some congress and something. So that's basically on-job training, I mean OJT. So elder radiographer teach how to use and also and the clinical topics. On the other hand, what we can provide to the radiographer. So it is, for example, refresher training. So some newcomer in charge the angio system, for example, before CT or MRI. So we can plan for the application training. What is this function? What is doctor perspective and something? So we can provide other refreshers training to the participant. So one is solution from my end. And also I will provide in session 2. So I show the smart simulator and the PEP Connect learning platform to you. So this is one solution for the education tool from the Siemens. But actually, so it is important thing. I mean, so experience, to get experience a lot is quite important in the clinical cases. So that's why the basically on-job training is first step in Japan. All right. And next question.
Yeah, Hajime, I think one of the mention coming from Pak Ari is, as you know that in Indonesia, in our education for the radiographer level, after pass from diploma degree, absolutely yes, we can continue for subspecialty like the MR system, CT system. Could you share in the Japan situation, there are the Cathlab intervention become the subspecialist after diploma degree, Hajime-san?
Sorry, I didn't get your point.
Yes, I mean that after pass, all of the radiographer student, after pass from diploma degree, 3 years education, we can continue for specialty majority. Let's say adding 1.5 years for MR system or CT system or ultrasound system. Maybe this is like the sharing education environment in Japan. It's mean that they are the Cathlab intervention become what we call like the option for the education majority in Japan. I mean that let's say after pass from diploma degree and then we will continue for the bachelor degree, they are available option for the radiology intervention.
Structure is a bit different in Japan.
So quite different, yeah.
Yeah.
Because in Indonesia, let's say for a diploma degree, all of the student will get the lot of information and basic knowledge regarding radiography, fluoroscopy system. And then if you're interesting to get specialty for the CT, you should take 1.5 year for the specialty majority, let's say CT and MR, yeah. Yeah, but in Indonesia, we don't have the specific or majority education for the intervention radiology. And how about the Japan situation?
I see. I get your point. So, yeah. Radiographer Society has a certificate for the Master of Interventional Radiographer. So that's why if you interest in the IVR case, I mean, so angio case, so you can register the test and also measure the room environment. So something like those measurement. So we have to submit those report and also check the understanding and something. So we have a specialized certificate for the IVR radiographer in Japan. So it expires after 5 years, I mean. So we need retesting and also resubmit some those report and something to the society. So that's mean it's different environment from the Indonesia. So in Japan, we have a specialized IVR education or certification protocol.
Oke,
Ya.
very clear. Thank you, Hazime.
Ya.
Ya, Mas Ari, cukup jelas ya, Mas Ari, penjelasannya ya. Jadi memang berbeda nih, background spesialisasinya antara Indonesia dengan Jepang. The second question, Hazime-san, coming from Pak Ari also. Pak Ari mentioned that sometime in the real situation in Indonesia, for the Cathlab environment, sometimes the cardiologist team excluding the radiographer, because with the summation that nursing staff can handling for the Cathlab for the routine position. And maybe could you share the Japan situation? How about this situation? The radiographer profession should be mandatory in the Cathlab environmental or something else? Thank you, Hazime-san.
Yeah. So as you mentioned, so in the electrophysiology case, so radiographer works exactly reduced compared with general cardiac cases. So doctor use same working angle and also look for the, card and something. So the mapping system. But the examination time is quite long. So that's why we have to consider the radiation dose information as well as possible, reduce as well as possible. So that's why sometimes radiographer witness the ablation case until end of the study. But as you said, no work a lot in the EP study. Same situation in Indonesia. So, but sometimes we can provide like this left ventricle free volume image and make a good working angle and something. Yeah, but no a lot of jobs there. Yeah, it's the same. Iwan, are you muted?
Mungkin Mas Iwan bisa menjelaskan ke audiens yang lain ya. Mungkin agak kesulitan bahasanya Mas Iwan.
Ya, baik. Jadi pada beberapa pelayanan di rumah sakit yang ada di Jepang, ya radiographer itu sudah menjadi suatu bagian di dalam pelayanan radiologi intervensi. Kenapa? Karena seperti gambar yang dicontohkan oleh Hazime nih, dia mencontohkan ada gambaran 3D left ventricle, kemudian ada gambaran 3D angio vessel. Nah, gambaran-gambaran ini adalah gambaran yang diperoleh dengan teknik-teknik khusus. Seperti tadi disampaikan, dibutuhkan pengaturan injeksi. Berapakah flow rate-nya, berapa Pascal satuan sistem yang diberikan, PSI-nya, berapa PSI-nya. Nah, yang tentu saja teknik ini adalah sangat spesifik. Jadi, bukan hanya dikarenakan alasan bahwa alat ini alat radiasi, ternyata di balik itu semua cukup banyak teknik yang ternyata kaitannya merupakan ranah atau pengetahuan radiographer, sehingga radiographer menjadi bagian tim yang satu kesatuan tidak dapat dipisahkan di dalam pelayanan radiologi intervensi. Jadi seperti itu. Nah, sementara untuk terkait dengan tadi yang disampaikan edukasi pendidikan untuk level radiologi intervensi di Jepang sudah sampai ada pendidikan master. Jadi S2 ya, S2 untuk radiologi intervensi, dan itu pun mendapatkan seperti kalau kita bilang seperti STR dan SIKR, pengakuan dari badan profesi setiap 5 tahun sekali bahwa yang bersangkutan memiliki kompetensi di bidang radiologi intervensi. Mungkin itu untuk menjawab pertanyaannya Mas Ari. Cukup jelas ya Mas Ari ya? Mudah-mudahan cukup jelas, atau jika ada yang mau ditanyakan lagi, silakan. Boleh bertanya langsung atau lewat kolom chat, kami persilakan.
Itu di kolom chat sudah ada pertanyaan Mas Iwan.
Oh ya, baik. Hazime-san, we have the question from the floor. The question is meaning, how is the role of the fluorosafe in Siemens Artis system? How is the role fluorosafe in Siemens Artis Z system? Question coming from Bu Devi.
Can you hear me?
I can't.
Okay. I muted.
Yeah. Please
So,
repeat again.
yeah. So after stop the fluoroscopy, so we can see the last image hold on the live monitor, and then so the store fluoro icon highlight on the touch screen controller or your control monitor. So after we press this button, so it store automatically. So, but the general rule is the maximum 124 frame is maximum. Okay.
Yeah. Okay.
And we only store the previous fluoros. We couldn't get 2 previous fluoro and 3 and something. So this is immediately fluoroscopy only.
Iya, oke. Understood Hazime-san. Jadi penjelasan dari Mr. Hazime, setiap kita melakukan pengambilan gambar, baik fluoroskopi atau gambar sine. Gambar sine itu adalah gambar yang ketika kita menginjak pedal, gambaran itu langsung tersimpan, tidak harus kita simpan. Nah, kembali ke gambar fluoro, ketika kita melakukan pengambilan gambar, biasanya di layar ketika pedal fluoro atau menggunakan hand switch button atau foot switch button kita lepas, akan muncul gambar terakhir yang tadi dia bilang, atau bahasanya LIH, last image holding, gambar yang terakhir. Nah, maka prosedur yang disarankan adalah gambar yang terakhir itu yang kita lakukan save fluoro. Gambar itu akan tersimpan dan bisa kita panggil kembali jika sewaktu-waktu diperlukan oleh dokter. Mungkin seperti itu Bu Devi prosedurnya ya.
All right.
Yeah. Hazime, I think I got the question from other participant. The question is meaning you already explained that in the Cathlab procedure in Japan for diagnostic procedure, the comparison seen with the fluoro is 60% for fluoro time, correct? And then for the treatment, cardiologists will use 70 until 80% for the treatment.
Yeah.
Yes. The question is, if we do the diagnostic procedure, why? Yeah, the acquisition bigger comparing with the treatment? Because in the student opinion that should be for diagnostic, acquisition is smaller comparing with the treatment. Thank you, Hazime-san.
So firstly, the total amount is totally different. So for example, I will check. So total dose. Okay. But interventional case, so total dose should be, for example, 100 milligram, for example.
Yes, total. Yeah. Okay.
Yeah, but in terms of the procedure time, this is only 5 minutes, for example.
Oh, I see. Yeah.
Yeah. Time, this is for an hour, for example. So that's why totally different. I mean, so total value. So in terms of diagnostic case, so the fluoro time also reduced. Acquisition time also reduced. But in terms of the treatment case, the doctor used the fluoro all the time, around 50 minutes and something. So that's why the percentage of the fluoro also increased in this situation.
Yeah, okay, Hazime-san, got the point. Thank you.
All right. For example, fluoro time around 15 minutes, something. But for example, FL time around 3 minutes. So this is totally different, something like this. All right.
Yes, so the different based on the procedure time duration. Oke, thank you
Yes,
Hazime-san.
Yeah.
Baik, rekan-rekan, ada lagi yang ingin ditanyakan kepada Hazime? Mungkin kepada teman-teman panitia pelaksana, ini sesi 1 saya rasa sudah cukup banyak ya pertanyaannya dan saya rasa ini cukup menarik. Kita bisa lanjut ke sesi 2, cuma mohon informasi lebih lanjut, apakah boleh ada break time dulu nih, mungkin ada rekan-rekan yang mau ke toilet atau mungkin menyiapkan minuman dan cemilan, kita bisa break dulu mungkin 10 menit, mohon informasi lebih lanjut dan arahannya, terima kasih.
Ya Mas Iwan, mungkin boleh di ini dulu untuk break dulu untuk sesi 2 masih Mr. Hajime ya.
Okay, Hazime-san, before continuing with the session 2, we will have the break time, okay? And 10 minutes. So it means that we will continue 10 minutes after.
All right, so we will start 11:45 around, okay?
Yeah. Okay.
Okay.
It is okay for you, Hazime, and we have
Yes.
break for 10 minutes, and we can continue after that. Okay.
All right. So
Yeah.
thank you for a lot of questions from your end. So see you on the session 2. So I will introduce the clinical part in the session 2.
Baik.
Okay. See you later.
Jam 10.34 ya. Mohon izin, kita lanjut lagi jam berapa nih? 10?
10.45 aja nggak apa-apa.
10.45, baik. Oke,
Yes.
makasih banyak.
Terima kasih Mas Iwan.
Recording stopped.
Baiklah, kepada para peserta, karena waktu sudah memasuki pukul 10.45, maka istirahat sudah selesai. Okay, because it's already 10 minutes and the break is over, let's move on to the session 2. For Mr. Hajime, the time and place is yours.
Right, thank you. So I will share my screen. Can you see my presentation already?
Not yet, Hajime.
Right.
Okay, no.
All right. So let's get started. All right. So welcome back. So session 2. So here. So session 2's agenda is here. So we focus on the clinical topics in session 2: cardiac, neuro, and abdomen. So, and I introduce our latest technology in the last session. All right. So first topic is cardiac. So now I'm showing general workflows in the cardiac intervention case. It's called PCI. So, but I want to touch a basic knowledge about a coronary tree and working angle definition as a first topic. All right, so go to the basic knowledge.
Recording in progress.
All right, so maybe you have already learned or known this content. So coronary tree is structured by 4 parts: RCA, LAD, LCX, and these coronary trees supply blood flow to heart muscle wall. So LAD and LCX are derived from the left main trunk. So if left main trunk occluded, so the blood flow wasn't supply left ventricle wall, so it means so blood circulation will be stopped. So this is quite severe situation. Reperfusion is necessary as soon as possible. Okay. So look for each vessel. So RCA is segmented number 1 to 4 in AHA segment. So an important side branch derived from RCA, so like a conus branch. So it supply blood flow to RV outflow port. So if this blood flow stopped, there is a risk of and sinus node branch is occluded. So the bradycardia happens. So RCA has important side branch for controlling heartbeat. So on the other hand, so LAD is segmented number 6 to 10 HS segment. So number 5 is always left trunk. All right. So LAD cover left ventricle wall. So it means important to keep blood flow for whole body. All right. So LAD has 2 big side branches, the first and the second diagonal, number 9 and 10. Okay. The last is LCA. So it is segmented number 11 to 15 in AHS segment. So LCX also has sinus node branch. So in the clinical field, the doctor says segment number while diagnostic and intervention case. So we need to get knowledge about the AHS segment number. All right. And next is working angle for LCA. Okay. So severe routing angle are required in the diagnostic case and also intervention case. So it is quite important steps to evaluate coronary tree correctly. So basically, so cranial view. So cranial view evaluate LAD. So caudal view evaluate LCX basically. All right. In RCA, there is only one vessel. The angulation number was reduced a bit. So we couldn't evaluate bifurcation part in LAO and RAO view, but in the cranial view, we can get enough information of the bifurcation here. All right. So why multi-angulation are required? So please see these images. So this is RAO cranial view for LAD. So LAD number 6 part has a stenosis. This part is quite close to the number 9 diagonal. All right. But we cannot see enough bifurcation area in this angulation. Okay. So change to another angle. You can find the bifurcation part as well. Okay. So in cardiac case, so we need a specific information, not only stenosis figure, but also bifurcation and around information. All right. So that's why so the multi-angulation are required. All right, so go to the procedure step. The first topic, so first is pre and start procedure. All right, so firstly, please confirm puncture site. If the patient use arm approach like a radial approach, so we need to prepare arm folder, all right? And if patient uses a glowing approach, femoral approach, so we need a body support for it. And hemodynamic system is mandatory for the cardiac case. Injector and another imaging system like IBAS is case by case. Okay. So, and do not forget to prepare defibrillation as a complication support tool. All right. Okay, now we start procedures. So the image doesn't work. Okay, so the doctor engaged the cut. Can you see my screen, Iwan?
I can see your screen, but I can't see your video, Hajime-san.
All right.
Yes, now the video is running well.
All right. So the doctor engaged the catheter to the left main trunk, so control acquisition are required. So in this case, so we can see the number 6 stenosis. So dual angulation is needed as we discussed previously. So I will try to, let me check. So I'm sorry, it doesn't work in this area, sorry. And after that, okay, so we need to create a reference image. So doctor confirm image during the procedures, okay? And so store angle information on the system. So Siemens has a direct position function to store the system position. All right. So I will back to this image later. Okay. So what is important when take control acquisition? So please see these images. So this image taken with cranial 30 degree, okay? So but proximal of LAD overlapped on the LCA, all right? So you can find here, it is overlapped on the LCX. So that means proximal side and bifurcation information are lacked for the next step, okay? So if the angulation changed to the cranial 45 degree, so it is possible to avoid overlap between LAD and LCX, okay? So you can get better information than cranial 30 degree in this situation. So you can find the proximal side here. So we can avoid the overlap area between the LAD and LCX. So I guess, so please consider or advise good working angle from radiographer, okay? So the coronary tree shape is individually, so there is no specific answer as common, all right? And you can use a CT diagnostic image to consider good working angle, okay? So we want to evaluate LMT, left main trunk, and bifurcation of LAD and LCX. So in this case, so now we use LAO 50 and LAO caudal 30 degree. So on the right side, so LAO 50 and caudal 45 degree. So which is better? Now, so LAD 50 and caudal 45 degrees is better, as you see. So it is helpful to avoid overlap side branch, and the bifurcation part is better visible, okay? So radiographer have a chance to look for nice working angle with another modality like this, okay? It is quite helpful for the doctors to decide treatment strategy and it make treatment more safety, all right? And so guide wire closing. So after control acquisition, the doctor closed the guide wire to the coronary tree. So all the devices are progressed along guide wire, all right? So in this case, 9. So therefore, 2 guide wire is required, okay? So one is LAD main branch. So the other for number 9 diagonal branch, all right? So when treating the LAD, so blood flow to the bifurcated branch vessel, so to the number 9 branch may be blocked, all right? Be prepared to protect the bifurcation blood flow as well, okay? So the stenosis part has a bifurcation branch. So we need a 2 guide wire. So one is the protect side branch, the one is a main branch. All right. And I want to introduce FFR device here. So FFR device is one of the guide wire which has a pressure calculation function between distal and proximal part. Okay. So FFR is calculated the ratio by dividing distal pressure by proximal pressure. Okay. If the ratio is under 0.8, so enough blood flow didn't supply to the distal vessel, so mean must do the PCI. All right. So in this image here, the degree of stenosis part is around 25% to the under 50%. It isn't look severe stenosis. Okay, so actually, so use the quantification in this region, the stenosis rate is only 32%. So, but tried to the FFR ratio was 0.71. So we should do PCI in this case. Okay. So FFR evaluate vessel condition, not only visual of the stenosis, but also functionality perspective. All right. And the IVUS is also common evaluation tool in coronary intervention. Okay, so IVUS use ultrasound wave to evaluate inside blood vessel. So the benefits are visible plaque buildup, dissection of the vessel, so calcification information, and decision of stent landing zone. Okay, so IVUS is a common tool to evaluate the vessel from internal. Okay, and then, so go to ballooning and the stenting. Okay, so on your left, PTCA balloon is displayed. So it has a metallic marker. In this image, we have a two marker on edge of the balloons, right? So it is metal. So therefore, we can confirm this marker on the floor. So this balloon used for the measurement distance and the decision of the stent size. All right. And after ballooning, so compare stenosis region. So we can see the stenosis part released after ballooning. Okay, you can find here. We have a stenosis part here, but after ballooning. So it is still stenosis, but a bit released the stenosis rate. All right, so PTCA stent. So it is put on the PTCA balloon. So also has a metallic marker. So confirm balloon marker on the fluoroscopy and decide landing zone. And after that, the inflate balloon, the coronary stent will be deployed in the coronary tree. All right. So current coronary stent were made thin, reduce metal amount. So it is for patient benefit. All right. So sometimes we couldn't see stent visualization with normal fluoro and acquisition. Okay. So clear stent support this issue. All right. So it is improved coronary stent visualization. So doctor can confirm stent strut, kinking, and degree of expansion and calcification information. And useful to confirm balloon position for post-ballooning. So if stent expansion was not enough. And if you treatment wrong disease vessel, so need to add more stent in the proximal side. So each stent should be overlapped. We can confirm this overlap with clear stent function. All right. So I will show the clinical images. So this is for post-ballooning. So balloon marker have to inside the deployed stent. And we can find this part is not expanded as well because of the calcification here. all right? And overlap the both stent here. This is a deployed stent. The next one is additional, so next stent in the proximal side. Okay, so this is important for doctors and also patient to proceed treatment safety and efficiently. So clear stent support this situation. All right. On the other hand, so we have one more option called clear stent live. Okay, so it is improved stent visualization as real-time scene. Okay, so clear stent provides static image. Okay, calculation time is required, but clear stent live is real-time processing, so it makes smooth workflows. Okay, so and available for the post-ballooning and the stent deploy. So we can see the both scene like a normal scene and also enhanced image at the same time. All right. So, and I want to introduce support application for chronic total occlusion. Okay, it's called the Cto Guidance. So Cto Guidance is support chronic total occlusion case. So Cto case is commonly past more than 3 months. It means not acute situation. Okay, so blood flow supply via the collateral vessel. Okay, so Cto study is required advanced technique for the treatment. So due to heavy calcification, unvisualized distal vessel. So in this case, so RCA has distal vessel like red line, but we cannot find any more. All right. So what is benefit of the Cto guidance? So it is possible to detect coronary tree by using CT image with automatic calculation. Okay, so occluded vessel also detected. So all coronary tree are displayed. So they are displayed as a color-coded view and color wave. So color-coded blood vessel fraction. So so red color means fraction against the detector. So doctors look for nice angulation with which target vessel displayed as a green color on the color-coded image. All right. So it means no flexion. So that's why easily progress the guide wire. All right. So we can find the red color here. So this means the flexion here, but this part we can find only green. So that's why no flexion. So doctor possible to progress the guide wire along the line. All right. And the color wave use the same MIP display. It is useful to the confirm calcification information. So as I mentioned in session 1, so multimodality approach is current trend. So please note these applications. So we can find calcification information there. So sometimes these information couldn't find on the fluoroscopy and acquisition, all right? So that's why Cto guidance is needed for the Cto case. All right, so after stenting, so to the post-acquisition. So after treatment, post-acquisition is required. So for comparing pre and post. So we have to reproduce a system position with pre-acquisition. Okay. So as I mentioned in the pre-acquisition session, the system can store angulation information on the system. All right. We can use a direct position function in this time and compare between pre and post-acquisition images like this. So on the left, we have a pre-procedure acquisition. So the stenosis part is here. So the post-procedure image here. So we have to use the same angulation and system position and compare the stenosis part side by side. All right. So this is actual cardiac study workflow summary. So, but it depends on the doctor's thinking. Okay, some of the steps are skipped, like IBUS and FFR. So please look for what you can do as a supporter in the real clinical field. All right. So next, go to the neuro. So today I introduce neuroaneurysm coiling workflows. So we have a several steps for treatment. Okay, let's get started. So step by step. So please prepare some head holders to avoid patient motion. So it is important for neuro procedures. So as I mentioned in session 1, in DSA acquisition, patient motion so that's why patient position should be fixed and also communicate with the patient before DSA. All right. So go to the control acquisition. So after puncture, so doctor progress a catheter to the target vessel. So like an aortic arch to the common carotid artery, subclavian to the vertebral artery. Okay. So in this case, the load map function is required. Okay. So Siemens has several types of the load map called like overlay, DSA roadmap, and also classic type load map. So on the load map image, the vessel signal displays as a white signal and background anatomy is subtracted. Okay. The device signal like a catheter and the guide wire shown as a black signal. All right. After selected target vessel, so take a control acquisition. So it takes until venous phase. So doctor evaluates target region and the blood flow circulation. For example, collateral flow or venous occluded or not. So on the frontal image, so usually use a cranial degree like a town visualization. So lateral image use a 19 degree. The vessels are evaluated from 2 directions. All right, so go to the pre-3D acquisition. So 3D acquisition performing. So in this case, Dyna3D protocol used. So it is high contrast imaging. All right. The target is high density object, like an enhanced vessel by the contrast medium or bony structure and some metal if the patient done some procedure in previous. Okay. If high resolution mode option there, it will be better. Okay. So subtracted 3D protocol is recommended on our system. So we get 3D reconstruction data set after 3D. Now mask the bony structure. So native field, so both signal, so like a CTA imaging. All right. So this is a sample of Dyna 3D. So we can see vessel shape with volume rendering visualization, right? So Dyna 3D Micro is our high resolution mode, okay? So visualization is a bit different from the normal mode, all right? So this is a high resolution mode. This is a normal Dyna 3D. So we can see the fine distal vessel on the micro image, okay? It is very close visualization to the 2D DSA image. Okay, so intracranial vessel. So doctor confirm penetrant branches which must save vessel flow. If these important vessel occluded, some neurological symptom occur. All right, so that's why high resolution imaging is required in pre-3D acquisition. Okay. For making better image quality, so injector setting also important. So in terms of the flow rate, delay time, and so on. Okay, so these values will be changed by the catheter position and the catheter size, also vessel diameter. So we look for the correct value and discuss with the doctors. And it is important to keep contrast medium during rotation. So this image is real clinical case one. So we must keep contrast medium injection in while rotation time. Okay. For example, so catheter position was ICA proximal with 4 French sides. So flow rate set as a 3 milliliter per sec. So delay time 2.2 seconds. So delay time measured by time of delay time means the time of contrast medium reach to target from catheter tips. Okay, so it is calculated previous control DSI acquisition. Okay, and total value was around 22 milliliters. It is calculated by multiplying flow rate and injection time. So injection time means the delay time plus rotation time. Okay, so someone feel this calculation was a bit difficult, but it's okay. So if you experience it a few times. All right. So after 3D, so some measurements are required. For example, vessel diameter, aneurysm size, volume, and so on. So all vendor has analysis application. So on the Siemens system, it's called neuroaneurysm analysis. So it is semi-automatic analysis tool. We select aneurysm point and distal and proximal vessel point. So system calculate result and show it on the workstations. And our application provides a virtual stent planning. It is used to simulate the stent size and the decision of landing position. All right, so I will explain what is neurostent data. Okay, go to the coiling. So while coiling phase, so roadmap function is required. So this benefit are here. So we can see aneurysm shape during the roadmap because we can find the vessel signal as a white signal. All right, and the background anatomy and the catheter position should be confirmed on the native image. Okay, so in this case, the coil signal only as a black on the subtracted image. So doctor can confirm coil shape and the figure in the aneurysm. Okay. And I want to introduce one of roadmap functionality. It's called show progress. Okay, show progress is used quick demasking. It is quite helpful during coiling case. Okay, so doctor deploy first coil in the aneurysm, so we can see the coil mass as the black signal like this. Okay, then so use the show progress, the system demasking. After that, coil mass will be subtracted. So we can see next coil as a black signal. All right, so that means the doctor see controlling coil only. So possible to confirm second coil shape and figure on subtracted image. Okay, if the first coil mass signal maintained like this, the second coil signal get buried in it. Okay, so that's why so show progress function is quite useful. Only show the current controlling coil visualization. But sometimes this step will be skipped. So it depends on the aneurysm shape. Okay, so normal aneurysm, it has a narrow neck port. So deployed coil are held down at the neck port. Okay. On the other hand, if aneurysm hasn't narrow neck port, it's called wide neck aneurysm. So deployed coil cannot be held at the neck port. It means there is a risk of coil drop to the vessel side. Okay. So for wide neck aneurysm, stent assist coiling is performed. So in this case, insert two catheters. So one is for aneurysm, the other is for stenting. So while coiling, stent is half expanded, okay, to make a virtual neck like this. Okay, so we don't have a neck part here, but when we half expand the neural stent, so we can make the virtual neck part like this. Okay, and then stent is fully expanded like this. So normal vessel flow is kept in the stent side. Okay, and in this situation, so there are no risk of coil drop to the vessel side. So stent support coils from vessel side. All right. So back to this slide. So virtual stent is useful for planning the stent position. So that's why we have to calculate neck coverage and distal point and proximal point. So it is quite helpful for the neural stent cases. All right. So when neural stent used for the aneurysm case, we should evaluate the stent itself. So neural stent is quite small and thin strut. So that's why impossible to see on the floor. Okay. Then, so dyna CT is required for stent imaging. So in the stent 3D, confirm these points. So stent crimping to the vessel wall, neck coverage, stent landing point, and stent kinking or fracture. So diluted contrast medium is required for stent 3D. So the rate depends on the kind of. We have to take like this 3D stent imaging. confirm the stent kink or fracture. So the stent cover all the neck region here and crimp to the vessel wall. Okay. So if expansion is not enough, there is a risk re-occluded. So that's why we have to take a stent 3D image after they deploy the stent. All right, so go to the post-acquisition. So after coiling, so we do the post-DS acquisition. So in this case, the system position should be set to same position of the control acquisition. So for comparison and confirming treatment result. So we propose to use the automap function. So this function called reproduce system position completely. All right. So doctor is able to compare pre and post image easily. All right. And post Dyna CT. So after neuro procedure, hemorrhage confirmation is required. So Dyna CT is one of easy way to get the CT-like image and evaluate the soft tissue. So protocol selection is quite important. 20-second DCT head, 109 kV is the best protocol on our system, right? It has the most projection number and high kV plateau make beam hardening reduced. Okay, the low contrast resolution is a bit lower than CT, but we can detect hemorrhage like these images. All right. So this is end of neuro part. So go to abdomen procedures. All right. In the abdomen part, I introduce liver embolization case workflow. Okay, so this is a general procedure step for liver embolization, mostly liver embolization case for hepatocellular carcinoma called HCC. So 3D imaging is key point. So let's get started. So prepare body support for keeping patient safety, and head rail is needed to avoid streak artifact from arm on the 3D image. All right. The first step is a CTAP and SMA DSA. CTAP is CT during arterial photography. So this is venous phase imaging, all right? Contrast medium inject from SMA, all right? SMA. So HCC part is nourished by liver artery. So that's why HCC part is visualized as a low density area in CTAP, all right? On the other hand, normal liver tissue is nourished by portal. So therefore, liver tissue enhanced in the CTAP. So we look for this difference of the contrast medium enhanced in CTAP. So SMA DSA will be skipped when CTAP performed. So the normal liver tissue enhanced like this, and HCC part get a low density area like this. All right, celiac DSA and CTHA. So as I mentioned, HCC is nourished by liver artery. So HCC part will be enhanced in the artery phase. So doctor confirm feeding artery to tumor and the tumor enhanced in the DSA image. So we can find the feeding artery from the catheter tips like this, and we can find the vessel and tumor enhanced like this. All right. So what is a CTHA? So CTHA is CT hepatic arteriography. So clinical checkpoint are here. So HCC enhanced in the early phase. On the other hand, HCC part make ring artifact in delay phase. So this ring artifact, ring enhance. So this ring enhance is characteristics of the HCC. So it guide to decide HCC part completely. All right. So after CTAP and CTHA, doctor compare each image side by side. So, and decide HCC part, so which has low density in the CTAP, so enhanced in the early phase and ring enhanced in the delay phase. So this is kind like very close to the liver dynamic CT imaging. Okay, so our Angio product so provides same like this workloads. So back to the CTHA image. So CTHA is artery phase. So that's why we can get liver artery vessel tree with MIP visualization. Okay. So this image show feeding artery and tumor itself. So doctor can be defined the vessel which should be embolized. So we can find like this tumor, and we can find the fine feeding artery like this. Okay, and DynaCT has high resolution than CT. So the correction matrix is quite smaller. So it is around 616 micrometer. So, and isotropic voxel signal. Okay, so therefore, we can see the fine distal vessel like these images. Okay, CT cannot be shown like this fine vessel. So due to of the correction matrix and rectangle voxel signal. All right. And I want to introduce support application, single embolization guidance. So this application detects feeding artery automatically and define the bifurcation point. So the vessel are colored with different color. So doctor can find the route to tumor and it guide to the catheter progression way. All right. And we can change vessel visualization to color-coded display. So it is very close to the Cto Guidance. So the vessel tree show us two color. Red means the tangent against the detector. So green mean in parallel against the detector. So doctor look for green line in the bifurcation or flexion vessel area. So they get the correct catheter direction way with green line. And this image works by linking to the C-arm, position, and angulation. All right. So if the catheter reached to the feeding artery, so embolization started. So in the embolization period, so dose controlling is needed. So doctor confirming embolizamic material movement, so feeding artery to tumor. Okay. So sometimes some doctor use acquisition. Okay. But okay. So the angio system is able to store fluoro image as a scene. As I explained in session 1, so radiation dose of the fluoro is lower than acquisition. So embolysmic material mixed up with contrast medium, so we can get enough visualization on the fluoroscopy like this. Okay, and please use store fluoro function instead of the acquisition. All right. And if doctor allowed to reduce pulse rate of the fluoro, so it is quite helpful to reduce total dose. Okay. Also, collimation is useful in this situation. So these contents will be big impact for patient radiation dose amount. Okay. If we change pulse rate 10 to 7.5, so if 20% reduce, all right? So this is quite a big impact for the patient dose. All right, so after embolization, so doctor confirm embolization effect by the DSA, all right? So now embolized material found on the image, and if some feeding artery still into the tumor, so continue to inject embolysmic material again, right? So we can check the effect of the embolization from the post-celiac, so artery DSAs. And some doctor required post-3D imaging with medium, okay, to confirm the embolysmic material spread. Okay, so in this case, we suggest to use a low dose protocol, low dose 3D protocol. So CTAP and CTHA, so S signal noise ratio is important. So that's why we suggest 6-second dynacity body protocol for it. So this is best protocol for body, all right? On the other hand, post 3D, so we only confirm embolysmic material. It has high density, so therefore we can get enough visualization even if we use low dose protocol. Okay, so it makes 35% dose reduction than best protocol. Okay, so you can notice noise impression on it. So, but it. All right, so abdomen part was finished. So if you have any question, so please write on chat and speak up in the QA session. All right, so go step to the introduce our technology. All right, so in the last part, I introduced robotic intervention technology. So it is called Corindascope PAX GRX. So this system set at table side. So operator controls the system remotely via joystick. So it make new safety working environment by reducing significant radiation dose for operator. So I will share this video. All right. So as we see on the video, so it is quite new concept. So joystick is like a gaming controller. So maybe younger doctor good at it. Okay. So now it is developing now. So remote PCI, like from Jakarta to Medan, apply near future. All right. And the next one, so I introduced a smart simulator. So this is one of our new running method. So we can access virtual system monitor and run basic training, advanced application, and so on. So smart simulator are using remote training and pre-training in this COVID situation. So our travel is limited. So therefore, we provide this tool and training by remotely. So I will show you smart sim monitor and demonstrate of Cto guidance. All right, so I will change my screen. So can you see my screen?
Yes, Hajime, we can see your screen.
All right. So this is the smart simulator of our workstations. Okay. So this is a cloud virtual simulator, but there are a lot of clinical sample cases here. Okay. So now I introduce how to work the Cto guidance like this. Okay. So Cto guidance is used CT image. So the thin slice data is required. So in this case, I will use 0.75 millimeter here. So load to the 4D task card. Yeah, you can find the CT image from this one. All right. And this slot is single application software. So we found the Cto guidance like this. Okay, go to OK. So now system calculate and also detecting coronary arteries automatically. Coded with color wave view. Okay, so now we detect RCA and LAD and LCX. If you change the angulation like this, also the vessel color changed like this. Okay. And for example, hide all object. So we only see the calcification image, something like this. Okay. So now I focus on the RCA region. So that's why only show the RCA region. So, but the doctor now facing engage is quite difficult. So because in this working angle, so we have a red color in the ostium point. So that's why we have to look for the green line, something like this. So the ostium area shown the nice working angle as well. And after engage the catheter, we change the angulation like this. All right, we get this green angulation in the proximal side. So, but the middle part, we face a red color. So that's why change to the color and also look for the green line on the image. Like this. All right. So that means the CTO guidance is useful for the CTO cases. So, but we can demonstrate, and you can use this smart simulator to understand the coronary CTO guidance step and also any other applications. So just I introduced the aneurysm analysis and also EP planning, embolization guidance, and so on. So Siemens application provide same like this session with you, and also you can use this virtual monitor and virtual system on your laptop. Okay, so this is a introduction of the smart simulator. Okay, and back to here. Okay, so that's all in the session 2. So any other question? So please, Ivan, please guide to me.
Okay, Hajime-san, thank you very much for your presentation, very comprehensive and detailed. Okay, actually we already have some of the question in the row, and please me forward to you. The first question coming from Kiki Rizky Yandani, and she has very sweet greetings for you. Mr. Hajime, konnichiwa. Konnichiwa, Hajime-san. Watashi wa Kiki. The question is about how often doctor in Japan, they are use quantitative coronary analysis to measure the length of the stenosis area. Instead of it, in Indonesia, the cardiologists more prefer to measure the length of the stenosis area by manually. It's mean using tip of the wire with the length of 30 millimeter. And then the second question is how accurate quantitative coronary analysis technique to determine the stenosis length. Thank you.
Okay, so for the first question, so quant application is mainly used in Japan. So doctor always use the quantification, I mean, so QCA application for all stenosis cases. So, but as I mentioned, so sometimes we couldn't get enough stenosis rate. I mean, it looks not severe stenosis. So, but the some issue happened in the heart. So that's why they use FFR device instead of the QCA. And also, yeah, still QCA is mainly used in Japan. Yeah. Okay. And how accurate is QCA is determined in the length of the stenosis. Yeah. So QCA. So we need a calibration. For example, catheter calibration and also isocenter calibration and something. So the accuracy is depend on the calibration rate. So if the calibration factor is totally different from the actual rate, so the also the result also wrong. So, but we have some accurate range. For example, if we use the isocenter calibration for the certain image, so if the object shift from the isocenter the 1 centimeter, so I mean we include a 1.5% wrong 1.5%.
1.5%.
Yeah. So that's why, so the accuracy is depend on the calibration method. So if the calibration is correctly, so the QCA, so we can find the correct value on the QCA application result.
Okay, so the conclusion is in Japan, strongly recommended to use the QCA application comparing with the let's say manual measurement, since with the QCA application, one of the prerequisite and the most important thing is we should conduct the calibration, correct? And the calibration make the measurement become the accurate, absolutely, yeah?
Yeah.
Okay, thank you, Hajime.
Yeah.
Second question is regarding the frame rate, Hajime-san. So normally for the adult coronary procedure, we use the 15 frame rate per second. And then sometime for the cardiac case, the doctor asks to reduce the frame rate and change, become 10 frame rate per second. The question is, if we change the frame rate, there are any different selection of the frame rate between pediatric? Okay, I think the question is, based on your experience in your previous hospital, there are different frame rate selection for the adult and the pediatric patient, Hajime-san. I think this is the main question.
Okay, thank you for your question. So, yeah. So from my experience, so the common frame rate for adult case is 10 frames per second, as you mentioned. So, but for pediatric case, so the child has a tachycardiac around 100 to more than 150. So that's why sometimes the high frame rate is required. Okay. So, but our suggestion is to use more than 15 or 30 frame rate for acquisition. So because we have to reduce the contrast medium, and that's why we have to use the high frame rate for the pediatric case. So in terms of the high frame rate acquisition, so we should reduce the dose setting. So it is closed discussion in the session 1. So we have to think a balance. If the high frame rate is required in the pediatric case, so we should reduce the radiation dose setting. Okay, for example, to half of adult cases and something.
Ya, oke, baik. Jadi penjelasan dari Hajime bahwa justru yang terjadi di Jepang adalah pada kasus pediatri. Kenapa? Karena pada pasien anak-anak biasanya tachykardria, jadi heart rate-nya itu sangat tinggi sekali. Dan ada suatu sistem balancing. Ketika kita menaikkan frame rate, settingan dari dose plate-nya itu harus diturunkan. Okay, Hajime, I think we have the raise hand from Mr. Ari Sasongko. Mr. Ari Sasongko, he is a senior radiographer from National Center Hospital in Jakarta. Thank you, Mas Ari. Please go ahead with your question, Mas Ari. Masih di mute kayaknya Mas Ari, maaf.
Oke, terima kasih Mas Iwan, thank you. Okay, I have question about the measurement of the level stenosis of the coronary artery. Usually, before we measure the level stenosis of the coronary artery, the doctor asks the radiographer to freeze one image as a reference to measure. And as we know, the cardiac has a systolic pace and diastolic pace.
Yeah.
And my question is, should we choose one of the pace, to freeze, to get a better result of the measurement? And is there any difference result from both of the pace, in relation to get a measure of level of stenosis of the coronary artery? Thank you.
Yes, thank you for your question. It is a bit difficult to answer. So actually, we use systolic phase for the LAD lesion. So it is measured in Japan. So, and also diastolic volume, diastolic phase used for RCA. It is close, very close to the CT coronary imaging. All right. So, but I don't have any different from systolic and diastolic phase. So it has a big difference or not for the stenosis rate. Yeah, but actually there is no rule. So our recommend volume for QCA or diastolic for the QCA. There is no answer. I'm sorry.
Okay.
Iwan, are you muted?
Yeah, sorry. Yeah, Hazimesan, next question is coming from Kiki. The question is, does the root map image in Siemens generate from DSA image only?
I thank you for your question. So I will show these images. So actually we have a several type. So overlay reference image and the DS roadmap. So as you say, so these function use a previous DSA acquisition image. Okay. And on the other hand, so we have a classic roadmap type. So this is use a fluoroscopy. Okay. So injection is needed for the vessel map. So that's why we can choose which is your favorite in the roadmap function. Okay, so that's why we can select two of this. So this is non-subtracted roadmap function. So this is something like this. So both use the DS acquisition, but the classic roadmap is use the fluoro dose setting for roadmap. All right.
Okay, thank you, Hazimesan. Yeah, I think we still have the next question. Wait for a second. I'm going to check. A moment. Okay, the question is like this. You already showed to us the development of the 3D acquisition in the Cathlab system. The problem is, comparing with the development of CT technology, we already operate for 16 slices. And then we have the 64 slices, even more than 220 slices. It's meaning to get scan as fast as possible and then to reduce the motion artifact. And how about a strategy to reduce the motion artifact on the Dyna CT acquisition?
Yeah, thank you so much. So time resolution is so CT's time resolution is better than Dyna CT. So more or less, it take 5 seconds in the rotation time. So that's why. So this is weak point for our Angio 3D. So because volume data taken in the 5 seconds, okay? So, but one solution for the motion artifact, and we have a motion artifact correction for reconstruction. It is available for the subtracted image, also native image. So the system detected the patient motion and calculate each frame from by using the raw data and the interpretation of the motion signal as well as possible. So that's why in the current, so the latest software version, we have a similar motion artifact correction for 3D imaging.
Ya, oke, thank you. Jadi teman-teman, kita tadi ngelihat ada 3D akusisi. Nah, ini ada pertanyaan bagaimana kita mengurangi motion artifact, sementara di CT scan saja kan diciptakan ada CT 64, CT 128 yang scan-nya lebih cepat untuk mengurangi motion artifact. Nah, Mr. Hazime jelaskan bahwa di Cathlab itu untuk melakukan Dynacity, mendapatkan gambaran 3D, itu dibutuhkan waktu 5 detik untuk melakukan 3D akusisi, yakni si arm-nya berputar mengelilingi tubuh. Di samping itu ada beberapa aplikasi untuk mengurangi motion artifact, baik pada gambar natif ataupun gambar DSA. Jadi seperti itu kurang lebih penjelasannya. Oke, Hazime, I think I have the last question in my pocket.
All right.
The question is, you already saw to all of the participants regarding the Cathlab technology development, and then what is I think this is regarding the clinical alignment with the Cathlab technology development. At the moment, how many disease type can cover by the Cathlab procedure examination? Hazime-san.
Yeah, thank you for your question. So a lot of case possible to cover. For example, the stenosis cases and the embolization cases and so on. So, but there is no limitation for the case type. Stenosis type and embolization type. Also, emergency case, something like a trauma case.
Oke, thank you Hazime-san. Jadi kita karena memang Cathlab ini tadi kita lihat ya pada beberapa contoh kasus ya, ada kasus neuro intervention, kemudian ada kasus cardio intervention, ada kasus onco intervention, ada kasus vascular intervention. Jadi ini cukup luas sekali ya. Contoh kalau misalnya kita membicarakan pada kasus cardio intervention, nah itu mulai dari kronik total oklusi bahkan sampai yang sifatnya kelainan, misalnya ada VSD dan lain skala, ASD, arterial septal defect, kemudian ditunjukkan hepatoseluler karsinoma, bisa dilakukan TACE, embolisasi, sehingga itu juga bagian dari treatment. Tumornya diblok, feeding vesselnya yang pada akhirnya tumornya mati, ketika nanti tumornya hanya sisa akar saja, baru dilanjutkan dengan prosedur surgery. Jadi ini memang sudah sangat luas sekali cover penyakit-penyakit yang bisa dilakukan oleh Cathlab, tetapi yang perlu diingat bahwa Cathlab merupakan stase kedua. Ketika diagnosa sudah dilakukan, diagnosa sudah ditegakkan, Cathlab sebagai diagnostik, sebagai radiologi imaging yang mendukung prosedur treatment atau terapi. Mungkin itu yang dapat saya bantu sampaikan. Okay, Hazime-san, I think we are ready more for 6 minutes and very, very interesting. Baik, the last change, there are any question from floor? If you have a question, please. Ya, silakan. Jika masih ada pertanyaan dari teman-teman nih, saya persilakan. Kita sudah lewat 6 menit. Mungkin kalau masih ada pertanyaan, masih satu pertanyaan lagi. Tetapi jika memang sudah tidak ada, saya kembalikan ke panitia pelaksana. Terima kasih.
No questions
Okay,
so
no
far.
question. I think no questions so
Alright.
far. I think quite enough for us. And thank you for your sharing information for us,
Alright.
Hajime-san.
Yeah, thank you so much for your attention. Yeah, thank you so much.
Thank you. Yeah, bye, Hajime-san.
Can I leave now, or I can wait the PEP introduction session?
I think PAP will be including on the second session, Hajime-san.
All right.
Yeah, because on afternoon session, we still have the one CT session. Thank you, Hajime.
All right. So everyone, so thank you for joining in my session. So I hope it is helpful for you and a good experience for your learning experience. So if you have any questions, so please contact to Iwan. So Iwan also forward to me. So I will reply your question as well as possible. Yeah. So have a nice, great weekend. So thank you so much, guys. So bye-bye.
Thank you, Hajime-san.
Yeah, bye-bye.
Before we end today's occasion, we will have the documentation first. Kepada para peserta untuk diminta menyalakan video pada Zoom untuk melakukan sesi dokumentasi yang akan dipandu oleh teman saya, Devi Novia.
Hajime-san, sorry, maybe for the documentation session, could you open your camera, Hajime-san? Okay. Yes, okay.
For all the participants, please to open your video camera.
Terima kasih untuk MC untuk sesi terakhir dokumentasi. Untuk semua peserta diharapkan untuk menyalakan kameranya. Kita akan ambil gambar dari slide pertama. Oke. 1, 2, 3. Oke, untuk slide berikutnya. Oke, sudah selesai. Terima kasih MC atas waktunya.
Okay, thank you for Hajime-san for the very informative presentation and very great answers. And I want to say thank you to Mr. Iwan Setiawan for lead the answer session, dan untuk kepada seluruh peserta yang telah berpartisipasi dan bertanya pada kelas hari ini. Baiklah, karena kita sudah berada di penghujung acara, kegiatan kuliah tamu perkembangan teknologi radiologi jurusan Teknik Radiodiagnostik dan Radioterapi Poltekkes Kemenkes Jakarta 2 tahun 2021. Sebelum kita tutup acara ini dengan seksama, saya selaku pembawa acara pada kesempatan ini memohon maaf sebesar-besarnya apabila ada tutur kata dan rangkaian yang kurang berkenan di hati seluruh peserta. Sekian yang dapat saya sampaikan. Terima kasih kepada semuanya. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, Hajime, thank you. See you next time.
Thank you so much, Mr. Hajime-san.
Yeah, thank you so much. Have a nice, great weekend.
Yeah.
See you.
Yes. Bye.
Thank you, Mr.
Thank you, Panitia, Mbak Sinta, rekan-rekan panitia semua.
Mas Iwan.
Makasih banyak. Ya.
Terima kasih. Jangan lupa habis ini kita masih ada satu sesi lagi.
Oke, siap-siap.
Jam 1 siang ya, nanti
Jam
untuk
1 siang.
peserta ikut bergabung lagi. Ya. Saat
baik.
ini boleh, mungkin habis ini kita langsung tutup, panitia untuk akan tutup link Zoom-nya. Dan untuk link Zoom yang jam 1 sudah kita share juga, bisa langsung nanti jam 1 bergabung.
Baik.
Gitu.
Kita izin sholat dulu.
Iwan,
Ya,
semuanya.
makasih.
Ya, okay.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.